Hello and welcome to the Morgan Lens class. This presentation was adapted from the Morgan Lens instructional PowerPoint. Effective emergency eye treatment must be prompt, prolific, and prolonged. All right. In order to be prompt, treatment must be started as soon as possible. Treatment should not wait until you arrive at the emergency department. To be prolific, the treatment must reach all regions of the eyes. It must dilute the contaminant and wash away all that particulate matter. To be prolonged, the treatment must be continued uninterrupted for a sufficient period of time. For chemical burns, you must irrigate until the pH of the eye returns to normal or neutral. This may take several hours.
Water sucks. Gatorade is better. What?
Well, no, water doesn't suck. The third edition of Principles and Practices of Emergency Medicine states that irrigation may be done using water, beer, urine, or any other reasonably safe fluid. Mortan recommends the use of lactated ringers due to a pH similar to that of tears and because it has a buffering capacity. Luckily, they made that recommendation because it would be extremely difficult to urinate into a patient's eyes for several hours. Ocular burns represent 7 to 10% of all ocular trauma presented to the emergency departments. 84% of those are chemical burns, with an acid-to-alkali ratio varying from 1:1 to 1:4 depending on the study. 16% of those are thermal burns. 15 to 20% of all patients with facial burns exhibit some sort of ocular injury. In 1995, approximately 1/3 of all corneal transplants were done on eyes that had sustained chemical burns. Even if the eye cannot be saved, irrigation should be performed in an attempt to maintain enough healthy tissue to allow for this corneal transplant. You can use the Morgan lens for any of these listed conditions. Acids are defined as proton donors. Their strength is based on how easily they give up their proton. A very strong acid has a pH of 1. An ocular acid burn produces coagulation necrosis. The scar that forms limits further penetration of the acid. Alkalis, also called bases, are proton acceptors. Their strength is measured about how tightly they bind to their proton. A strong base has a pH of 14. They produce liquefaction necrosis, which does not limit or slow their penetration. Therefore, they are more damaging than acids. Both acids and bases are called caustics. Concentrated forms of either may generate significant heat when diluted, resulting in thermal injury. This is most pronounced when a small amount of fluid is present, such as in our eyes. Large amount of fluid, or irrigation, dissipates the heat in addition to diluting the caustic substance. Alkali burns are the most serious burns that can occur to an eye as they rapidly cause liquefactive necrosis. The damage continues as the alkali rapidly penetrates through the ocular tissues. It takes about 5 to 15 minutes to reach the anterior chamber of the eye. It's important to note that alkali burns may not be the most painful. The alkali can quickly penetrate the corneal stroma and interfere with the sensory nerves. The nerve damage may actually produce an anesthetic effect as the alkali continues to penetrate into the anterior chamber and the retina, causing permanent blindness. Airbags in cars are a growing source of alkali burns. A reaction of sodium iodide inflates the bag, but it also produces aerosolized powdered sodium hydroxide, a very strong base. In addition, there may be inert powders used to keep the bag from sticking. That may cause irritation to the eye. Sodium and potassium hydroxide are also found in cleaners or Clinitest tablets. They generate considerable heat when mixed with water. Clinitest tablets generate temperatures of nearly 160 degrees Fahrenheit when dissolved in 1.5 milliliters of water. Calcium hydroxide is found in household bleach and pool chlorination solutions. Calcium oxide, also known as lime, is the caustic ingredient in cement. It generates heat when mixed with water. Ammonia is found in cleaners and detergents. Magnesium hydroxide and phosphorus are found in sparklers and flares. Hydrofluoric acid is a weak acid that can produce liquefaction necrosis and therefore acts more like an alkali. Therefore, it causes burns that are very serious. It is found in glass etching compounds, rust removers, and cleaners. Sulfuric acid generates considerable heat when diluted, found in automobile batteries, toilet bowl cleaners, and drain cleaners. Nitric acid is used in metal refining, electroplating, engraving, and manufacturing. Hydrochloric acid is found in toilet bowl and metal cleaners, plumbing applications, and laboratory chemicals. Acetic acid is found in printing, disinfectants, and hair care products. Vinegar is a type of dilute acetic acid. For common irritants, it is not necessary to monitor pH. You should irrigate until all the pain is gone, which usually takes 20 to 30 minutes. Always check for corneal abrasions and treat them accordingly. In order to use a Morgan lens, you will need an IV delivery set for each Morgan lens you intend to use, an irrigation source, preferably lactated ringers, a towel to catch the runoff, any topical ocular anesthetic if it is available, and pH paper if you plan on testing the eye's pH level. The first step to insert a Morgan lens is to instill topical anesthetic if available. This may relieve the involuntary action of the eyelid squeezing shut, which will help you with insertion. You will then attach the Morgan lens to the IV tubing. If possible, remove contact lenses, but do not delay irrigation if you are unable to remove those contact lenses. Step 2 of insertion requires you to start a minimal flow of irrigation solution prior to insertion. Then you'll have the patient look down and you insert the lens into the upper eyelid. Next, you'll have the patient look up, retract the patient's lower eyelid, and drop the lens into place. Then you release the patient's lower lid over the lens and adjust the flow to the desired rate. Step 3 of insertion is to secure a fluid collection device to the side of the patient's face. The Mediduct is shown here, but you can use a towel. For chemical burns, you should continue irrigation until pH returns to normal. There is a Morgan lens instructional chart with additional instructions for treatment of other injuries. Remember, do not let the Morgan lens run dry. In order to remove the lens, make sure that you continue the flow of irrigation fluid. Have the patient look up, retract their lower eyelid, and then slide the Morgan lens out. Once it is out of the patient's eyes, you can stop the flow of fluid. Recommendations on this page are from Goldfrank's Toxologic Emergencies. The purpose of irrigation is to dilute the offending agent, remove the offending agent, remove foreign bodies, and normalize the pH of the anterior chamber of the eye. If the offending agent is not chemically reactive, for example, irritants, solvents, non-embedded foreign bodies, experts usually recommend using 1 liter of solution or approximately 30 minutes of irrigation time. For acids and alkalis, the measurement of conjunctival pH should be used to determine the stopping point. The normal pH of tears is 6.5 to 7.6, but when measured in the cul-de-sac of the eye, normal pH is closer to 8. Therefore, 7.5 to 8 is a reasonable stopping point. In order to measure the pH of the eye and not the irrigation solution, irrigate with 2 liters of solution per affected eye, wait 5 to 10 minutes, and then measure the pH. If not in the 7.5 to 8 range, repeat the cycle. However, for serious exposures like strong acids or any alkali burns, 2 hours of additional irrigation after the conjunctival pH reaches 8 is recommended to ensure neutralization of the anterior chamber of the eye. Remember to begin irrigation first and ask questions later. The severity of the injury depends upon the length of contact time, the pH or molarity, the concentration, the viscosity, the volume, the physical form of the contaminant, the heat created by the reaction, and the associated toxic substances. Do not delay the initiation of irrigation to remove contact lenses. Contacts were once thought to trap chemicals underneath them or to absorb vapors in the air. Studies have shown that neither of these occur. Contact lenses, either hard or soft, may actually form a barrier that prevents or lessens chemical burns, and soft contacts do not increase exposure of the cornea to vapors. These are the contraindications of the Morgan lens: protruding foreign bodies, any penetrating injuries, if you suspect or there is an actual rupture of the globe, and instilling anesthetic agents with known allergies. The manufacturer recommends the use of lactated ringer solution for irrigating due to the pH levels. Tiers of a pH of approximately 7.1, while normal saline has a pH of 4.5 to 7.0. Lactated ringer's pH of 6.0 to 7.5 is closer to the pH of tears. Also, the buffering capacity of the lactate ion found in lactated ringer solution returns the pH to normal more quickly when used with either acidic or basic contaminants. Normal saline may also cause discomfort and/or morphological changes to the eye. Obviously, patients won't necessarily be happy with us inserting objects under their eyelids after they just had an injury. You need to assure the patient that the insertion of the Morgan lens will quickly alleviate the pain. Some of the benefits touted by the manufacturer for using the Morgan lens includes that 100% of the irrigation solution is delivered to the eye. It frees up staff from holding tubes by the patient's eyes. Patients can be moved while the irrigation progresses. Patients can rest comfortably. And per the manufacturer, it is cost effective. In summation, burns are the most urgent of ocular injuries. Irrigation must be started as quickly as possible. All surfaces of the eye must be flushed thoroughly. Irrigation should continue until the pH is within normal range. Alkali burns may require hours of irrigation, and severe infections may require hours or even days of irrigation. Here is the manufacturer's video on the Morgan lens.
Continue with free-flow irrigation. We see a lot of trauma here, but injuries to the eyes, they're different. So when a patient comes in with multiple injuries plus ocular trauma, chemical burns, thermal burns, foreign bodies, visible or not, the eyes can't wait. Fast, immediate treatment of the eye calms the patient, makes it easier to work on other injuries, which is why emergency treatment of the eye demands a fast, bilateral, hands-free method, one that gently irrigates or applies a controlled dose of antibiotics to the cornea and the conjunctiva. So just like over 90% of the emergency departments in the country, we use the Morgan lens. The Morgan lens is molded to fit the unique curvature of the eye and equipped with directional fins, attached tubing, and an adapter. Consider the alternatives for a moment. Traditional methods of eye treatment are inefficient, ineffective. But the Morgan lens, it's so easy to use. Doctors used to tell you to just patch the eyes and bring the patient in. But what if you could begin flushing the eyes and neutralize ocular pH levels en route to the hospital? all with this little device designed in the field by an ophthalmologist for treating severe infections. As a volunteer physician in Vietnam, Dr. Lauren Morgan ran across numerous ocular injuries. And today, thanks to his in-the-field invention, we find the Morgan lens works in all types of environments. Application is easy. First, if one is available, apply a topical ocular anesthetic. Then peel open the sterile packaging, and with the Morgan lens delivery set, attach an IV bag to begin a minimal flow. You can also attach a syringe for a smaller, more controlled application. Have the patient look down and insert the lens under the upper lid. Then have the patient look up, retract the lower lid, and drop the lens in place. Adjust the flow to the desired rate and absorb the outflow with the Mortan Mediduct or with towels. After insertion, the Morgan lens works on its own. Your hands are free to go to work on other injuries or transport the patient from the accident site to and throughout the critical care area. The revolutionary Morgan lens separates the cornea and bulbar conjunctiva from the palpebral conjunctiva, irrigating both surfaces and preventing symblepharin from forming. The Morgan lens is the only device to provide a positive and multi-directional flow throughout the cul-de-sac. This keeps the cornea, conjunctiva, and normally untreated inner eyelid thoroughly flushed. Foreign bodies, even the kind that can't be seen, are removed effectively and thoroughly. Once inserted, the Morgan lens floats on the very layer of solution it provides, separating itself from the tender ocular tissues and vaulting the cornea, never touching it. As the lens floats above the eye, preventing further damage from eyelid movement, the flushing process soothes the injury and provides instant relief to irritated eyes. Patient testimonies overwhelmingly confirm that the Morgan lens is more comfortable than conventional handheld methods. In fact, on many occasions, in cases of endophthalmitis, panophthalmitis, Stevens-Johnson syndrome, corneal abscesses, alkali burns, doctors have used the Morgan lens for continuous irrigation for 7 to 10 days, removing them only long enough to examine the eyes. Join 90% of the country's emergency departments and make the Morgan lens your first line of defense for ocular injuries. To place an order for your emergency department or company infirmary, just give Mortan a call at 1-800-423-8659. The Morgan lens, clearly the most comfortable, effective, and easy to use ocular irrigation system available.